Now, in terms of treatment, we're going to talk about, one of the things that I want to kind of reinforce here today is that I think the one-size-fit-all or categorical way of seeing depression is just not very helpful, particularly if you're actually working with kids who are depressed. And I think a better way is to think about these different dimensions, emotions, thoughts, behavior, and their relational world. So I think in general, we should be thinking about people along these spectrums. Now, you can see that bottom one, and I have these two terms, and I tried to keep all the wordiness out, but to me these are important terms, and we're going to talk about these terms. And the terms are anaclitic and introjective states. Okay? Now, anaclitic is that state, or the orientation, I should say, that it's very other-focused. You're focused on others, you're focused on relationships, whereas the introjective state, it's more when you interpret your depression, you look inward for that interpretation. So this is the person who's going to be more self-critical. So people, and I want to say that it's not like it's a category, meaning it's not like we have these anaclitic depressive people and we have these introjective depressive people. It's a dimension, just like we described before. It can change at times, okay? And it can change throughout a session. So we kind of always have to be assessed. In general, people who are anaclitically depressed, they typically have histories of early loss. They typically have histories of care, of abandonment, of rejection in their life, basically. So it is a very caregiver-driven, I think, at times. These are people that tend to always be focusing on relationship problems. People keep leaving me. They feel unloved. They feel unlovable. They may feel very lonely at times. They feel just weak, inadequate, helpless, hopeless. Sometimes they describe sort of vague senses of emptiness. And a lot of that probably has to do with early caregiver loss. In the past, people talked about this as maybe abandonment depression. Now, in terms of these people, if there are some personality traits with these individuals, they tend to be the more dependent kind of personalities. They tend to just be very needy, empty people. A lot of dependency-related issues with these individuals. And they may have more sort of borderline kind of traits, but the borderlines that are much more sort of impulsive. So more like the histrionic kind of borderline. Now, the introjectives, on the other hand, the people who have more introjective depressions, these are probably the more indicative of what like DSM is describing. The ones that have more common types of major depressive episodes, where they have lots of self-critical attitudes. They talk about feeling guilty for things that they've done, that they're a terrible person at some level, that they question their self-worth. These are people that have terrible self-esteem, things like that. And even in the face of good things in their life. There might be some issues of anger that are involved and things like that. These people tend to, if they have some personality traits, I would say in general, they have more narcissistic kind of personality traits. Not saying they have a disorder, but that they may, like, for example, try to hide that sense of inadequacy through sort of counteractive defenses, looking very arrogant and haughty and things like that. And of course, the borderlines, if they had some borderline characteristics, they'd be much more guilt-ridden kind of individuals. I'm a terrible person or something like that. Now, in terms of where the therapy go for these different states, for the anaclitic depressives, they tend to always focus on those interpersonal experiences like you were describing. My boyfriend continued to leave me or something like that. They just talk about the abandonments in their life. They talk about how dad left them, something like that. They talk about how mom wasn't really there for me or something. They really feel unloved. And I would say most times there is that secret fantasy that it's because of them. Even if they kind of say, I know it's not me, it's my mom, she's a substance abuser. there is a secret fantasy that it really had something to do with me. And I think a lot of times we see that when the types of relationships they continually get themselves into. And in terms of what therapy should be, what should be happening in the therapies, okay? For the Anaclitics, it's really about establishing relationships. And that's it. It's really about establishing relationships and helping people feel safe. Helping people feel together. Whereas the introjectives, on the other hand, a lot of times it's about challenging. So, for example, those that know about cognitive therapy and things like that, for those that are aware of cognitive therapy, a lot of times cognitive therapy is thought to be a very good source of treatment for these types of individuals because they have a lot of very faulty views of how they see themselves. And it's really important for you to kind of challenge those things over and over. And so you're helping to kind of establish a better sense of self in those individuals. Now, of course, these are themes. These things can change over time. One session, the person comes in and can talk about one subject, and another time they can come and talk about another. And they're going to require different types of therapeutic frames. So you have to kind of be able to work around. Now, people have actually done research on this. Aaron Beck, the sort of the godfather of cognitive theory for depression, things like that, he did a lot of research in the 80s, and he actually found, he didn't call them Anaclitic and Introjective, he called them different names. But basically what he found was that these people, if you match them with supportive treatments, they tend to do very well. And if you match these people with more cognitive therapies, they tend to do very well. The person who really perpetuates these terms, these anaclitic, introjective terms, his name is Sidney Blatt. He's a psychoanalyst, and he's been doing a lot of research for a long period of time on relatedness. He's actually looked at this as well and find something very similar, that people who are more anaclitically determined tend to do much better in therapies that are all about expression of emotion and to kind of continue to work on the relationship between the therapist and the patient. Whereas these individuals tend to do much better in more like traditional psychoanalysis, where, you have somebody sit behind you, you lay on a couch, and you just kind of free associate, and they just kind of make comments. They tend to do much better in these. Whereas those, they don't do very well in that treatment at all, because it's not enough closeness. There's not enough support. Now, when we're talking about transference and countertransference, what we're talking about here, countertransference is more the emotions that get pulled in you, in the therapist, or in the person working with the patient, while you're working with them. Whereas transference is much more about there's certain feelings that they have towards certain people in their lives that tends to get transferred to the therapeutic relationship or transferred to whatever function, whatever clinical function you're engaging. So with Anaclitics, a lot of times you tend to get this issues of reliability comes up, issues of dependability. These are the types of patient that you go away for 2 weeks, and they're like, so where are you going? Where are you going? And they're concerned, they're worried. These are the ones that would call you during that 2-week period. Because I think the fantasy is, you're not coming back, are you? And so lots of issues of separation, abandonment, and loss continue to come out. And we'll talk about this when we move to the examples in a moment. The introjective individuals, everyone's a little bit different, of course. But I know for me, some of the difficulties that I have working with these individuals is that you get into these competitions at times, where they kind of pull you into arguments, things like that. You got to make sure we refrain from those things. That we get to a point where you can give him what he truly needs, or give her what she truly needs, which is some type of compassion, instead of getting into a situation where you're going to destroy the relationship. Now, one of the things that's really difficult, I think, about just working with depressed patients in general is that they can be very exhaustive patients to work with at times. You leave the room and you feel very depleted. And, that's simply just a projection of their internal experience. They're just giving you a window into really what it's like to be them. In general, what we're talking about here is that we need different ways of working with different patients. Those anaclitic patients who feel very unloved, they need to be what's called held. And holding is a term that was coined by D.W. Winnicott, who was a psychoanalyst. And it's the idea that in the early caregiver relationship between a child and an infant, when the child was affectively dysregulated, you don't tell the child what's going on. All you do is you hold the child and soothe them. So in a therapeutic sense, what you're doing is, all you do is not physically hold them, but hold them in the room. You just reflect back to them and support them through that crisis. You don't interpret. You don't kind of jazzy it up by all kind of fancy stuff. All you really do is you're just there for them. And this type of intervention does very well with more of those anaclitically depressive individuals. Just like the research found, more supportive treatments work better with those individuals. And those supportive treatments include more holding. And I would say a lot of times you don't even use verbal communication. It might just be that you sit down, and instead of kind of sitting like you typically sit, which is like this, or however, I don't know how y'all sit, but that's how I sit, but you would come closer. You decrease the distance. You have a very accepting and open stance to them. And it may just be that that's your intervention, and that might be just good enough. Now, in containing, on the other hand, which is a term by Wilfred Bion, these are both object relation psychoanalysts, he describes containing. And containing is, I think, a little bit different. It's a little bit more psychologically advanced. It's the idea that we're going to try to provide some sense of meaning, some sense of cognitive structure to that affective state. It's not just that we're going to be there for them, but we're going to give them some scaffolding to kind of put themselves back together. So, for example, if you have a patient who is very sad and is crying in your room, and let's say we assume at some level that this is a person who has a more anaclitic depressive state. It may be that we just kind of sit there with her and allow her to cry and just be there and let her know that I'm not going anywhere. I'm right here with you. It may be that you just say, you look very sad. And that's the intervention. That's why you did all that school and stuff like that, to say that. Okay? Now, on the other hand, when you have someone who you would consider to be more introjectively organized, you may say something like, my comment produced some sadness, didn't it? Or you may say, he really hurt you, didn't he? And in that way, what we're trying to do is we're trying to provide some kind of frame for that person to understand their emotional experiences. Now, if we have that more introjective person and they're crying and I say, you look sad, they're going to think, of course I'm sad. What are you talking about? But in these situations, when you're talking about people who are more affectively disorganized, they're more fragile, they need just support. They don't need you to provide any fanciness for them. They just need you to be there. Now, for example, if that was anaclitically organized, and we kind of say, it seems like my comment produced some sadness in you, didn't it? That might dysregulate them even further because they're not in a spot to receive that information and really organize. All they need to do is just to be held.